So that also you can avoid if you are going in for regional anesthesia. We'll just discuss about regional anesthesia later. First, we will discuss about now with these changes in different systems of the body because of the obesity. Now, let us discuss about this particular patient now posted for lap cholecystectomy. So, how do you investigate this patient and how do you prepare this patient? How do you manage this patient?
First, routine investigation, sir.
Okay.
CBC, RFT, LFT.
No, because you don't say just routine investigation, because every investigation should be an indicated investigation. But an investigation is not indicated, you don't do it, because unnecessarily you will be producing pressure on the pulse of the patient and also on the lab people, their functioning. So only indicated test. So if at all, if you want to do even, as you said, routine investigation, or you can always say general investigation and specific investigation. That's how you classify general investigations and specific investigations. So what are the general investigations you would like to do? Especially hemoglobin is very important. Why hemoglobin is important in these obese patients?
Because if there's more chance of bleeding according to the surgery, we can anticipate and ask for reserving blood.
Yeah, do they bleed more?
Yes, I do.
Why do you think that they may bleed more?
Because you discussed before, vitamin K and all those factors will be reduced in this patient.
Okay, that is one. So liver may be affected and vitamin K absorption may also have a problem. Okay, that is one problem. Okay, what are the other reasons why they bleed?
Manipulation, because the incision may take longer duration.
Yeah, the surgeon may have to take a bigger incision because accessibility may be difficult, isn't it? So these are the reasons why these patients may bleed more than their counterparts which are not obese. So that is why hemoglobin becomes very important, so that you should calculate actual maximum blood loss that can these patients can tolerate, maximum allowable blood loss. So that's why hemoglobin is important. Okay, the other total count, differential count.
That will show the infection status of the patient, or
they are also immunosuppressed.
Yes, sir.
Yeah, obesity itself, plus they may also have comorbid conditions like diabetes.
Diabetes, yes, sir.
So naturally, they are more prone for infections. And especially the obese patients are highly prone for fungal infections. So that's why, it is better to get a total count, differential count. Okay, fine.
Platelets.
Yeah, platelet count, right.
LFT also we can do, sir.
Urine examination for, sugars, because they are almost 90% of the morbidly obese patients can also have diabetes. This patient may not give you a history of diabetes because diabetes is an incidental finding. That's a type 2 diabetes these patients will have. So that is why you have to, investigate these patients to know whether the patient also has either glucose intolerance. Invariably, he may have a glucose intolerance, or he may have frank diabetes mellitus. So for that, urine examination and also fasting blood sugar, yeah, postprandial and HbA1c. Okay, then proceed.
Liver function test, serum.
Yeah, liver function test, because fatty liver disease is very common, non-alcoholic fatty liver disease. And this patient over and above, he is also, occasionally or frequently he takes alcohol also. So 2 and 2 can be 8 or 9, isn't it? So synergistic effect can occur and more damage to the liver would have occurred. So liver function test becomes very crucial, right?
You can take a RFT also, sir, to rule out any other kidney related.
Yeah, renal function test, right?
And serum electrolytes.
Yes, serum electrolytes. Okay.
And PTI.
Yeah.
In case surgery.
Coagulation profile, right? Yes. Okay. Any pulmonary function tests are required?
Yes, sir. That is depending on the ASA severity, sir. If it is OSC, sorry. So if it is within 3, sir, you don't have to do any other investigation for sleep study or any pulmonary function tester. But within 3 to 5, you can see other
Better
indication like
feedback.
BMI is more with any other symptoms like NYHA class 3 breathlessness. If all those symptoms are there, then you can ask for sleep study and polysomnography. If it is severe, greater than 5 means definitely you have to go for sleep study and
That
polysomnography.
is about polysomnography. I'm asking you about pulmonary function test.
Sure.
Polysomnography is different than pulmonary function test, isn't it? It is not same. There you continuously monitor ECG, EEG, EMG, EOG. There's all these, grams are
Same criteria, we can use it for pulmonary function test as well. If it is within 3 to 5, we can ask for these investigations. So in that it comes
normally, you know that these patients have got a restrictive lung disease. Just to prove that they have a restrictive lung disease, you need not have to do a pulmonary function test. Because their FEV1 by FVC ratio may be normal. That is what is restrictive lung disease. All these parameters are reduced. Their total lung capacity is reduced, their vital capacity is reduced, their FEV1 is reduced. And you already know, you need not have to subject the patient for a pulmonary function test to know whether there is restrictive lung disease is there or not, because it will be there. So what is more important is you can definitely do some bedside lung function tests. That is more than sufficient, which you have done one bedside lung function test. You have done a mechanical functions, reserve, pulmonary reserve, cardiopulmonary reserve. You have done a breath holding time. That is one of the very important tests, breath holding time, and also the breath counting, number of counts in a single breath count test. Sebrasas breath holding and Sebrasas single breath count test. So single breath count test also you should have done, you have not done. But of course, this patient definitely has got a decreased breath holding time, isn't it? It should be more than 25. He has got 20. So definitely it has affected him. So pulmonary function test as such may not be required as such routinely. Okay. And he is also a smoker. There may be obstructive lung disease also in him, this patient. Isn't it? Because he is a significant smoking history is also there, 20 pack years is there. So this patient may have more problems as far as his lung functions are concerned. Okay, as such, you need not have to do a pulmonary function test. Okay. Then regarding his cardiac status.
We can do a routine. First is ECG we can ask for.
ECG, right?
Ask for echocardiography.
And ECG is very important, resting ECG also, because these patients may not come out with chest pain because they hardly do any exercise or they hardly exert themselves. So because of that, they may not come out with history of chest pain. That is what I already told you. They may be sitting for a long time. They may even move very slowly. And even for, climbing stairs and all, they may use lift. So they hardly will be doing any exertion activity. So they may not come out. So even then, you have to rule out the coronary artery disease. So ECG, resting ECG itself is fine. And how about stress ECG? In this patient, because his METs are less than 4, do you want to subject him for stress ECG?
Not sure. Maybe you can try echo, and if echo reading is
stress ECG, exercise stress ECG may be difficult in these patients because they may not be able to do it, isn't it? Because they may also have osteoarthrosis. So it is always better to go for a pharmacological stress test. Yeah, you can have dobutamine stress echo or myocardial perfusion test. Also, you can definitely get done to know whether how much involvement of the coronary artery disease is there or not. Then resting echo also becomes very important in these patients. Why resting echo is important?
Because of
Right ventricular hypertrophy.
there is some disease called as OHS that some patient will develop resting. No, that is.
They may develop cardiomyopathy, isn't it? Cardiomyopathy, biventricular failure is also biventricular cardiomyopathy is also quite common in these patients. Failure. So that again, failure signs may not be very clear when you examine these patients. There may not be edema, you may not be able to find out. JVP, rise JVP cannot make out because so much of part of fat. And tender hepatomegaly also may be difficult. So, and left ventricular failure also I may not be able to find out clinically. So definitely an echocardiography is very important to rule out any cardiomyopathy is there, any cardiac failure is there, what is their systolic functioning of the left heart, what is the diastolic functioning of the left heart. So that is a routine resting echocardiography, plus if possible, and dobutamine stress echocardiography, you may subject these patients. Okay. Any other investigations? I think most of the investigations you have told. Polysomnography, do you think that you require him to be, polysomnography has to be done?
His OSA score is more than 5, sir. So 5.
Yeah.
So he
So
can.
what is the advantage? Unless it is advantageous to you for managing this patient, there is no point in just getting a polysomnography done. What is his oxygen saturation? You have not mentioned the oxygen saturation. You have mentioned?
No, sir.
Room air 99.
Room air? You have
Sitting
mentioned?
position.
No, you have mentioned? Not
Nice.
mentioned, isn't it? It's very important to mention also.
Vitals.
Vitals you have mentioned.
Nice.
So, polysomnography, you'll know that how much of hypoxia and hypercarbia is developing. What is the score as far as, apnea-hypopnea index is there. So is it severe? Suppose if it is severe, he may require definitely a BiPAP or a CPAP in the postoperative period. So definitely, polysomnography may help us to know whether he requires a CPAP or a BiPAP, and how much of a CPAP or a BiPAP he requires to prevent the spells of apnea when he sleeps. So because once you put a CPAP device or a BiPAP device, definitely you can reduce the incidence of the apneic spells, isn't it? By applying pressure, it will prevent collapse of the airway or collapse of the pharynx. So that way, there is definite prevention of apneic spells. So, and these patients in the postoperative period, very commonly, they do develop all these obstructive airway problems, upper airway problems. So that's how by doing a polysomnography, you can know what is the amount of BiPAP or CPAP you require him in the postoperative period. So that will definitely help. Okay, so all these investigations you have done. Now, how do you prepare and proceed? And what kind of anesthesia you would like to give for his lap cholecystectomy?
Preferably GA, sir.
Yeah, preferably GA, because even if he was not obese also, you would have gone for GA only, isn't it?
It was an option, but
Majority of the laparoscopic surgeries, we go for general anesthesia. And many times general endotracheal anesthesia. In this patient also, probably you would be, selecting general endotracheal anesthesia. Okay, how are you going to prepare this patient?
you should.
Adequate pre-medication, sir.
Now, what pre-medication? Already I told you a case report. Should you give a previous day sedative pre-medication, or you avoid sedative pre-medication?
Yes, sir. Avoid sedative pre-medication. We'll be giving prophylaxis for aspiration prophylaxis.
That is next day, isn't it? The previous day, what you are going to do?
Counsel the patient, educate, and
Start on
get consent.
Start on DVT prophylaxis.
And Dr.
Aspiration.
Sadhana has asked for an ABG is indicated. Definitely ABG also. That is another important investigations. You can always get it done. ABG routinely, because already I told you that saturation may be on the lower side. You know exactly what is the PaO2 and PaCO2 and PA in these patients. Okay. So the previous evening, so definitely you would like to talk to him because, he will be very anxious. And you do not want to give him an anxiolytic also. So better to have a good talk with him and inform them about what you are going to do, how you are going to manage, how safe you will be for the patient. how you look after him in the post-operative period so that you can reduce his anxiety. Okay, so that is one thing. And again, nil per oral status. Always remember about these things when you are visiting the patient on the previous evening. So what the NPO status is same like any other patient, or is it any different?
Same, so 6 hours, 6 hours for solids.
Yeah, it is same thing for these patients also. It is not changed. So 6 hours for solids and 2 hours for clear fluids. Okay, that instruction you are going to give them. Okay, then so you'll take a consent, informed consent. So all these things should come, routinely. Okay, next morning you would like to give him aspiration prophylaxis. Very good. And will there be any problem in getting an IV line in these patients?
Yes, sir.
Difficult
IV access.
Yeah, difficult IV access is always there. So when you are doing a pre-anesthetic evaluation, you should always, look for a good IV access, and you have to mark it. And this you have to write down in the general examination when you are presenting. An IV access is there or not? In this patient, did you look for IV access when you examine?
Cubital was
Only cubital.
yes,
How
sir.
about the dorsum of the hand? Dorsum of the hand is usually
It was difficult due to multiple points.
okay. So it is difficult IV access. So if such is the case, many times what you may have to go for?
Central venous access.
Yeah, you may have to go for a central line preoperatively only. So because difficulty in getting an IV line, and if you have got one IV line and suddenly there is a problem with that, or if you want to give more fluids, you want to get other IV line, you may not be able to get another IV line. So in such situations, definitely you should anticipate these problems, and you have to get a central venous access. But for this particular surgery, if you can get a peripheral line with an 18 gauge, I think you need not have to go for a central venous cannulation. Okay, so now you have got you got a peripheral vein, 18 gauge, right? You have started with a fluid. You have started with a ringer lactate, balanced salt solution. Then what all the things? How do you prepare for this particular patient in the OT before bringing the patient into the OT? What preparations you will be doing?
First of all, the team should be educated about, they should be informed about the case, and they should know that this patient is very obese, and they should get appropriate instruments, and even the OT table should be adequately.
You have normal OT tables. They can sustain how much of weight?
110,
100 kgs.
Usually about 200 kgs.
100 kgs.
Or whatever the regular OT tables, what we have, they can sustain about 200 kgs. And these patients, sometimes they may be more than 200 kgs. Of course, your patient is 110 kg. So if the patient is more than 200 kgs, then you have to have a specially ordered OT tables may be required, especially in bariatric surgery units and OTs. They usually have OT table which can sustain 400 kgs of body weight. So, and another thing is, again, the width of the OT table. So you have to have a wider OT table also, because of the morbidly obese patients, their horizontal width will be very high. So that is another thing about the OT table. Even transferring these patients from the ward to the OT also will become extremely difficult, and transferring back also, isn't it? So at least transferring these patients, if they are able to sit in a wheelchair, at least it is okay. But otherwise, it will become very difficult. So those are some of the problems you can expect. Okay, so what are the other things which you have to prepare in the OT?
Standard monitors.
So difficult airway.
Double size.
So you have to have a difficult airway cart ready with all the equipment. there. That is one of the most important thing because you're expecting a difficult airway, and probably you may have to even go for an awake fiber optic intubation in these patients. So you have to keep ready all those equipment for awake fiber optic and also for going in for the airway blocks. We'll not discuss about the airway blocks because the previous difficult airway already we have discussed. So those things are again can be asked for you even when you are presenting an obese patient. All things about difficult airway you may be asked about. Okay, so you prepare for a difficult airway management, right? Then
Shift the patient and then
any other preparations? Like for example, even a BP cuff may not be, whatever the BP cuff you have,
double
may be very small for these patients, isn't that is another very important problem in these patients regarding the monitoring. So how much of your BP cuff should be, the lengthwise and then the breadth-wise? How much it should cover the length and then the breadth of the patient, your cuff?
75% of your
Length should be
75% of your
2/3 of the arm length it should cover. Breadth should be 1/3 of the circumference of the arm. So just remember like that, 2/3 and 1/3. So the bladder, it should cover 1/3 of the arms and it should be placed on the medial aspect because it has to block the or obstruct the, the brachial artery. So, but these cuffs, what we have, the largest cuffs also may not be, right cuffs for these patients. So, what you can do in such situations?
arterial monitoring.
One is, what I have found is, you can even tie this, the adult cuffs to the forearm. Instead of to the, arm, NIBP cuff, you can connect it, tie it to the forearm. And they have found almost, the near accurate blood pressure, NIBP blood pressures with a forearm monitoring. So you can use a forearm cuff instead of a arm cuff, same cuff. Or you require a specially designed large cuff for, getting the NIBP. So that is another very important thing. Okay. Next. Other monitors, what you want to keep ready? How about ECG? Is ECG easy?
ECG leads pulse ox.
Difficult. The waveform might not be accurate.
Because
So you may require to go for a what kind of electrodes? Required to go for a needle electrodes. Because you have to reduce the resistance offered by the fat or the impedance. So specially designed needle electrodes are there. So that you have to use for continuous recording of the ECG. Okay, so ECG again is a problem. Okay, then, and in major surgeries, I think, we were talking about the blood pressure, you may have to go for invasive blood pressure monitoring. That is definitely required in these patients. It will be more accurate. Okay. Then any other monitors you have to keep ready?
You can try BIS entropy or because sometimes adequate.
This procedure may not be such a long procedure, a major procedure for you to keep BIS if you have. But more important than BIS is definitely a peripheral nerve stimulator for neuromuscular junction monitor will become very, because these patients, they may have, they may not properly come out of neuromuscular blocking agents. So residual neuromuscular palsy is very common in the postoperative period. And if they do have residual neuromuscular palsy in the postoperative period, so they can definitely go for severe hypoxia and hypercarbia. So that's why a neuromuscular junction monitor is an important. Again, there you may require to use a needle electrodes. Okay, so that is another thing which you have to keep ready. And you also, because these patients are highly prone for intraoperative arrhythmias. So you have to keep things ready for managing intraoperative arrhythmias. Your drugs, including a defibrillator. Okay, these basic things you are keeping ready. Okay, now you are shifting the patient into the OT. Okay, now how do you induce this patient? What pre-medicants or pre-induction drugs you would be giving? And how are you going to induce this patient? What precautions you'll be taking during induction?
The induction agent we can give propofol, sir.
No,
And-
pre-induction drugs.
Induction.
Before propofol. Pre-induction drugs means before propofol.
Adequate opioids.
Yeah, short-acting opioids, because he is an hypertensive patient also. And first of all, you have to decide whether you can get an airway after induction or you should get the airway and then induce. In this patient, what you have examined the airway, what do you think? Can you get the airway after induction?
Slightly difficult.
Difficult, okay, but do you want to plan for awake intubation? That you have to plan, isn't it? So if you have planned for awake intubation, you always use airway blocks and then use your fiber optic scope and then get the airway first and then afterwards induce. Now, if you think that you can still manage with a video laryngoscope, you'll be able to visualize. So you can definitely go for, induction and intubation. Or one other thing is you can always do a check laryngoscopy, what we call it as. You can use your video laryngoscope and, you can spray the pharynx and using your video laryngoscope, and then gently you do a laryngoscope when the patient is awake and see if you can see any structures of the larynx. If you are able to see the structures of the larynx easily with a video laryngoscope, so then definitely you can induce and then you can manage. So with trial laryngoscopy, if you are not able to visualize anything there, it is better to go for awake intubation. Or if you think that the patient is not going to be cooperative for awake, video laryngoscopy just like that, because if you convince him, he'll be cooperative. If he's not cooperative, you can induce him with inhalation anesthetic agents. When he's breathing spontaneously, you can do a trial laryngoscopy. And then if you can see the laryngeal structures easily, you can definitely give muscle relaxants and then intubate. So anyway, these are the important things you will have to decide, when you do a pre-anesthetic evaluation. And these are the techniques you can adopt once the patient is in the OT. So once if you think that you are able to visualize the laryngeal structures, you think that it may be an laryngoscopy, maybe slightly difficult, but with video laryngoscopy, you can still intubate. Definitely, you can induce and then intubate. Okay. Now, the thing is, how much drugs the dose of the drugs to be given. So how do you calculate the dose of the drugs for these patients?
Barash says we can use lean body weights.
Body weights.
Most of the drug except for succinylcholine and
you see, there are important things like ideal body weight is there, then lean body weight is there, then corrected ideal body weight is there, and then appropriate body weight for calculating the tidal volume is there. So many different body weights are there. So, okay. So what is this ideal body weight? How do you have written some ideal body weight, 68 kgs, 63 kgs, something like. So how did you get this? What is ideal body weight? What do you use?
Ideal body weight is what a person is supposed to weigh according to his weight, height, and sex.
In males, it is
Broca's index.
Yes, sir.
Broca's
index, height 100 minus
height minus 100 in males.
meters.
And
Height in centimeters minus 100 in males. Height
100
minus 100
in females.
Yes, and so many kgs. That can be an ideal body weight. What is the corrected ideal body weight for obese patients?
In males, it is 50 kg plus 2.3 kgs for every.
No, that is the appropriate body weight for calculating the tidal volume. That is for Now, what is corrected ideal body weight
Adjusted body weight, sir.
or adjusted body weight? Both are same.
That is
What is
ideal body
adjusted
weight.
body? Huh?
Ideal body weight plus 40% of the ideal body weight plus
Total body
total body
weight
weight
minus
minus ideal body weight.
Yeah, difference between the actual body weight and
Yeah.
ideal body weight.
Body weight.
40% of that you
40%
add to the ideal body weight to
body weight, you
get
get
an
adjusted body weight.
adjusted or corrected body weight. So this is the one which you can use for calculating the drug doses. The corrected ideal body weight. Majority of the drugs, except what are the drugs where you go for actual body weight?
Succinylcholine.
Yeah, one is
And
succinylcholine.
low
and
molecular
low
weight.
molecular weight heparin.
Pardon?
Heparin, sir. Low molecular weight heparin.
No, don't bother about heparin. Intraoperative drugs. One is succinylcholine, another is propofol infusion,
Okay, sir.
then midazolam, then dexmedetomidine, then neostigmine.
Okay.
So these are the drugs you go for, and some books also give for cisatracurium. These are the drugs you go for actual body weight, and all other drugs you go for optimized or corrected ideal body weight. Okay. So now propofol loading dose, you go for corrected optimal, ideal body weight for loading dose. Because loading dose actually depends on the distribution volume, whereas infusions depends on the clearance. All those drugs which are lipophilic, so the distribution volume will be very high, isn't it? So you have to, change the amount of dose you have to give as a loading dose. So that's why you always go for corrected ideal body weight for the loading dose. So propofol, you can always go for a corrected ideal body weight. But when you're going for an infusion, because infusion depends on the clearance, so you can go for an actual body weight. For example, TIVA I want to go for. Then you go with actual body weight with propofol. Okay, so propofol you want to use in this patient, right? And then you want to use succinylcholine or for intubation?
Yes.
Would you like to go for rapid sequence induction? So before that, rapid sequence induction always starts with pre-oxygenation, isn't it? Of course, it also starts with counseling the patient and talking to him about what you are going to do and all those things. So pre-oxygenation is very important. Already we just discussed, because they have a smaller FRC and they have a higher closing capacity, they rapidly desaturate, and also their oxygen requirement is high. So you have to prevent desaturation during your getting the airway. So pre-oxygenation is very important. So how do you pre-oxygenate these patients?
For adequately for
Method of pre-oxygenation?
6 minutes, 100% O2, or 4.
No, you keep them flat, or you want to put them into 30 degrees head up position?
Head up, sir.
Yeah,
30.
30-degree head up position would always be better. Or you also can use for intubation also should be easy, isn't it? So you can definitely go for positioning for intubation also. What is this positioning for intubation? You can use it for called as
Ramping.
Yeah, ramp position or HELP position. Head elevated laryngoscopic position. HELP, isn't it? Head elevated laryngoscopic position. So how do you, what actually will be your target when you're getting a ramped or head elevated laryngoscopic position?
To prevent.
So what you want to make sure that, okay, this particular two things are in line?
The external auditory meatus aligns with the sternal angle, sir.
Yeah,
So,
external auditory meatus and suprasternal arch should be in line, isn't it? So that is what you make, so that it will be a easy laryngoscopy. So that is what you will be doing. And second thing is, so head elevated to 30 degrees, head end elevated to 30 degrees, definitely will improve the FRC. Okay, that you can use. Should you also increase the FRC by using anything like CPAP
Deep,
for this
sir,
patient?
deep we can use, sir.
No, PEEP, when he's breathing spontaneously, you call it as CPAP, isn't it?
Yes, sir. CPAP.
Yeah. So how much CPAP you want to use? So you can use 8 to 10 centimeter CPAP also for these patients. So that will keep their airways open. So improves the functional residual capacity, decreases the closing capacity, improves the denitrogenation, improves the oxygen reserve. So that will help in preventing rapid desaturation when you are attempting laryngoscopy and that is one thing. Second thing is, would you like to use para-oxygenation also in these patients? You know what is para-oxygenation?
Passively
Oxygenate the
oxygenating
patient.
Continuous nasal
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 prongs.
prongs you can use.
oxygenation, that is apneic oxygenation, or you can even use thrive also. So that is another very important thing you should keep ready, and you have to use this, either thrive or the continuous nasal oxygen, about 10 to 15 liters of oxygen. So when you are doing a laryngoscopy and intubation. Okay, so another here important thing about the management of the airway, because many of these laparoscopic surgeries can also be done under using a supraglottic airway device. Can we use a supraglottic airway device in this patient? Is it advisable for laparoscopic surgery?
Positioning might
You told because
Limburg and
One
reverse.
is
anatomy.
because distorted anatomy of the pharynx can be there. So that is one difficulty. So it may not be properly placed. Second thing is you consider them to have full stomach. That is second problem. Third thing is their compliance of the lung is very low, because already we said that FRC is less in these patients. So lung compliance is very less. So high airway pressures may be required. Plus pneumoperitoneum further decreases the lung compliance. Further higher airway pressures may be required. There will be a lot of leak around the supraglottic airway device. So ideally, in these patients, an endotracheal tube is the ideal choice, not your supraglottic airway device. So that is another very important consideration you have to keep. Okay, so you would like to use your video laryngoscope probably. So you have previously you had done a check laryngoscopy. You could visualize the laryngeal structures. So if you use the video laryngoscope, you have intubated. Okay, next. Okay.
Next,
setting ventilator.
ventilator setting, sir, after intubating the patient.
So would you like to use oxygen nitrous oxide inhalation anesthetic agents for these patients, or want to go for TIVA?
Nitrous is not preferred, sir.
Why nitrous you don't want to prefer?
Dilation of bowel loops might have.
It's because of the laparoscopic surgery. So, many places you don't use. What about your institution? Do you use nitrous oxide for laparoscopic surgeries? Or you are not?
Oxygen and air.
Air.
You are using oxygen and air. Okay. So you can always tell oxygen, air. Then inhalation anesthetic agents you would like to use or you don't want to use?
We'd like to use, sir.
Definitely you would like to use. And which inhalation anesthetic agent would be better in these patients?
Ideally preferable. Faster emergencies
Or
quicker.
desflurane?
Yes, sir. And
No, I did not hear what.
desflurane is more preferable because
Okay.
faster emergence is good with desflurane than compared to sevoflurane.
Why faster emergence with desflurane?
Because of its MAC value 6 and blood gas solubility is 0.42.
Yeah, because lower blood gas, not because of its MAC. It is mainly because of its blood gas
solubility.
being very low. So definitely you can use desflurane, but the problem with desflurane is tachycardia.
Yes, sir.
Because these patients may have coronary artery disease and you don't want to have tachycardia. And such situation, I think sevoflurane may be an ideal choice than desflurane. Definitely you can use sevoflurane. Okay, now how do you want to ventilate these patients?
We calculate tidal volume